Right, everybody. Thank you so much for joining us tonight. My name is Chris Pennell. I'll be moderating today's webinar. Tonight, we're doing the rerun of Sonosite's Behind the Scan webinar titled Diagnostic Shoulder Exam, Superior Shoulder. My name is Chris Pennell. This is the final part of a four-part series about shoulder ultrasound. And if you'd like to check out the previous webinars in this series, you can visit our webinars page on sonosite.com. With that out of the way, we'll get started. Before we begin, please be advised all attendees are muted. We'll conduct a Q&A session at the end of the presentation and demonstration, and you can type your questions into the Q&A box in the toolbar located at the the toolbar located at the bottom or the side of your screen. And that is only for the people on the Zoom webinar. If you're watching on YouTube, you should be able to find a link to get to the Zoom webinar if you want to ask questions. This webinar will be recorded and archived for future reference on our webinars page. Here with us today, we have Daniel Shelton. Daniel is the Director of Musculoskeletal Market Development for Fujifilm Sonosite. Daniel has spent 19 years as a dedicated musculoskeletal sonographer, and 14 of those years have been here at Sonosite. He now leads musculoskeletal market development, where he works to spread the word about the benefits of point-of-care ultrasound. We'll go ahead and get the recording started now. Thank you so much for joining us.
As Laura mentioned, this is the last part of a four-part series on the superior shoulder. There's not a lot going on the superior shoulder, so we'll throw in like an extra slide or two about a couple of bonus structures in the area that I found to be really fun while I was scanning in the superior shoulder region anyways. But first, we will stick with the acromioclavicular joint as a primary protocol structure of the shoulder. It should be looked at anytime you're evaluating shoulder pain. So just to give you an idea of the journey we've been through here, we started on the anterior shoulder, worked our way down through the lateral structures, such as the main rotator cuff of the supraspinatus and infraspinatus and subscapularis, and their various insertional variants and what we look for. And then we went to the posterior shoulder for the infraspinatus and teres minor, and also looked at the labrum and spinal glenoid notch. Today we'll be looking at the top side of the shoulder, the acromioclavicular joint. And then while we're in that area, we're just going to translate the transducer a little bit anterior, and we're going to aim the beam somewhat towards the coracoid, and we're going to be scanning the suprascapular notch. So just knowing that that could contribute to other pain generators in the area. So we'll keep it short and sweet today and rely heavily on Q&A. And just remember, this is the last of a four-part series. If you missed any of the previous webinars, they are posted at sonosite.com. And you can check out those webinars in their recorded fashion. Looking at the anatomy here, we're scanning primarily over our landmark of the acromion. I think that's the easiest to palpate if you're looking at an obese shoulder. So I tell people to poke a finger down on the back side of that transducer and feel for the acromion process, and then start from there, even if you have to go as lateral as the subacromial bursa. And then work your way up towards the anterior lateral shoulder while the probe is standing up about 12 o'clock. And you should see a break in that acromion. And at that point, you need to translate and twist your transducer until you see the clavicle. Something to keep in mind when we're doing AC joint evaluations is that this space should have a normal meniscal homologue inside, which is a fibrocartilage disc. That stays there when we're young and it disappears when we're old. So it can contribute to what looks like a loose body or something clicking or popping inside the joint when we do a dynamic exam. And to stress this joint, there's a few maneuvers we can do, but the most common is here, where we have the patient touch their ipsilateral shoulder, or contralateral shoulder, sorry, and we get those two bones to kind of clap together. And this way we want to look for the joint symmetry. Does the joint stay level? What's the integrity of this ligament here? The joint trying to sublux, is that little disc popping out? Do we have osteophytes inside or osteolysis of the bone? Do we just synovitis or inflammation in the area that can be treated? There's a lot that can be discerned in shoulder pain at the AC joint level. It's very tender, and you want to use sonation at this point. If you suspect something in the ligament or something deeper on the insertions of the ligament and that fibrocartilage disc, you may want to switch frequencies to the linear 19 megahertz probe that we'll be scanning with a little bit later if we have time. You can also stress the elbow by pulling down on the elbow and do kind of a weight-bearing exam on the AC joint. And that can be helpful for AC separation, just checking out the stability of that ligament again, and seeing if the joint opens up or gaps. I'm going to move on to the suprascapular notch. So this was a really fun structure to learn. And once I had it taught to me, it was kind of one of those things that you can't unsee. While you're in the area, you might as well just plop the probe a few more, like 2 or 3 centimeters midline, and aim the beam anteriorly and just see what you can see, and look at the supraspinatus muscle, which we discussed in the lateral shoulder webinar and the posterior shoulder webinar for atrophy. But if you have not explored the anatomy of the supraspinatus fossa down at the bony surface, this is a great time to kind of learn that landmark. Instead of making this webinar 3 minutes long and talking about the AC joint real fast, I figured we would just explore one other thing. So if this is not an interest to you or whatever, that's okay. But there is a lot of people out there that they've explored the shoulder in pretty good detail, but maybe there's just 1 or 2 things here and there that they would like to learn just a little bit extra. And I think this is one of those structures that does that. So this is a really superior view. Think of that Netter's view of the rotator cuff. We're looking down on the body. We're looking down on the shoulder. So here's the AC, the supraspinatus going underneath it in the supraspinatus fossa. We can see the beam is planted midline to the supraspinatus, which is like mid-coronal to the body plane. Patient positioning doesn't really matter. The patient can be nice and neutral for this exam. And my tip, and we'll show this tip while we scan, is to look at the posterior edge of the probe on the anterior edge of the spinous. Sorry, I'm going to back again, of the scapular spine. So.
This is Laura. I'd hate to interrupt you, but we're having some audio issues. It keeps kind of going in and out. So I don't know if there's something going on your end.
Let me move this microphone. Give me 2 seconds.
Okay, thank you. Well, please, everyone, we'll get right back in just a moment.
How's that? Any more clear?
That sounds better. Yeah, it sounded like a connection issue. It was like clicking, but
I may not be able to help much of a connection issue. So I'll try. Maybe it's lucky this is a quick webinar, right? Maybe my internet's about to go down. Who knows? Everybody's so used to this after 1.5 years of Zooming. It's pretty shocking. We haven't had worse problems, Laura. But thanks for giving me that heads up, and we'll trim that out of the recording. But anyways, I'll go over the live scanning tips and how to find this. Just know that we're looking for this structure at the supraspinatus fossa here, this little notch and ligament, and there's going to be a nerve that passes through there. That's a suprascapular nerve. You do want to throw on your color Doppler, whether it's power Doppler or the directional flow, it doesn't matter. But we want to locate this little artery, the suprascapular artery, and find out if that artery goes above the ligament or below the ligament, because there are some anatomical variations for that. And you can do therapeutic injections, or you can do diagnostic injections at this level. So this can be a part of your shoulder diagnosis, while not in a rotator cuff protocol manner, in a ultrasound guided needle injection around this nerve to see if that patient's pain generators go away just at isolating that suprascapular nerve. So this can be a great tool to kind of pull out of your toolbox if you've have other options. So what we're going to do now is just go over to the live demonstration, and then after the live demo, I just want to let you know that there's plenty of time for Q&A, and if you guys want to go ahead and have any questions ready in the chat portal, now's the time to start typing those. But I'm going to make this transition to the live scan, and just give me 1 second. Okay, so now we'll begin with the live shoulder demonstration. Today, we're going to be looking at the superior shoulder. Just like we had in the PowerPoint, will be the AC joint, and then we'll take a dive into the suprascapular notch and some of the other structures in that area. We'll be scanning on the Sonosite PX ultrasound system, beginning with the L15 to 4, 50 millimeter head, and then we'll move over to the L19, which is a 19 to 5 very high frequency transducer. So first we'll get started at the AC joint, and I'll talk a little bit about palpation first. On most patients, you can either start at the scapular spine and work your way forward until you can't feel anything else. So right here, I'm just kind of walking my fingers until I reach a bony stopping point. At that point, the acromion is taking a slight turn, and the clavicle is meeting it at that turn, creating the AC joint. So we should be able to set the probe right down in front of where I feel the spine of the scapula stop. To do that while I scan, I'm going to keep the left side of the screen to my patient's right. I'm going to hang a finger down on the back side of the transducer and use it as a palpation point right there in that little corner that I'm palpating right here. So I'm going to set that down and just place the transducer right in front of that palpation point. We'll get that really nice AC joint superficially. So that's just a good starting point by placing your finger back there. You can leave your finger back there, that's fine. But what we're going to be looking at right now is a few dynamic maneuvers to test this AC joint, and keeping your finger plopped down in that area may also help keep you stable. So screen right, pull my arrow up here. There we go, screen right. I've got the clavicle side, and I can see the trapezium starting to come over and invade the picture there. And then screen left, we have this bright cortical landmark, which is the acromion process. And then we can see the deltoid tendon attaching on the acromion here. So just under the deltoid here, we could see the subacromial space, which was described in the lateral shoulder webinar. So we won't go into too much detail here. But if you want to confirm your placement there, we could just have our patient do a slow kind of chicken wing maneuver and then watch that subacromial space glide really nicely. Here's also a good time to see if that's contributing to any clicking or popping around the AC joint. That way you can kind of modify or tailor your exam to also include that subacromial space. So go ahead and relax. There we go. Now let's go right back, following that acromion towards the clavicle. Here we can see that very, very superficial structure, the AC ligament. And we're going to test the integrity of that ligament. And there's also a little meniscal homolog here right in the joint. That will degenerate as we get older. And right now I'm seeing a nice healthy joint space. So what we're going to do is see if that meniscal homolog inside the joint wants to protrude out with any dynamic motion. So what I'm going to do now is have our patient just reach over and touch her opposite shoulder, and let's watch those two bones. Now notice they stayed nice and level. That's normal, that's great. What I don't want to see is either of these bones kind of sublux over the other. I see the AC ligament is perched up high, which is also normal, and it's the ligament and that meniscal homolog are bunched together. So go ahead and relax. There we go. And then the second maneuver I'm going to do is try to separate her AC joint by pressing down on the forearm here. So she can just keep her arm in her lap, and I'm just going to use pressure after the elbow bend, and I'm just going to press down. There we go. And what that does is help me pull on the actual elbow joint. There we go. And I didn't see any separation. So those are kind of the two main diagnostic maneuvers you can do to test the integrity of the AC joint. Let's take a closer look at this ligament here, the AC ligament, by switching over to the 19 megahertz linear, which is a smaller footprint zoomed in. So this transducer, it begins zoomed out for perspective. That way we don't get a little overwhelmed with what we're seeing in the shot, overly zoomed in. There we go. And then we will slowly creep our depth up so that we can appreciate all these little fibers. But if we do suspect calcium deposits or little avulsions or any other osteolysis, this is the transducer that you want to use. So I'm going to bring my depth up and my gain up just a little bit. Got our arrow back up. We can see that AC ligament really nicely. We can see its insertion and origin also very nicely. I don't see any calcium deposits or any avulsions. That's something that I'm looking for. You can redo those dynamic maneuvers at that point. Also turning on your color power Doppler at the enthesis or the origin of this ligament is very helpful if you suspect some sort of avulsion or other traumatic pathology in this area. At 19 megahertz, we can see the integrity or the internal contents of that meniscal homolog very nicely, and just get a very, very close look at it. Also for a procedure, I would recommend this smaller footprint transducer to kind of narrow your margin of error when doing an injection. You can typically do these out of plane. We have a nice arrow right there on the center of the screen, center of the transducer, and I'm just going to activate just a a center line. Here we go, right there, center of the screen. And that's going to correspond with the arrow underneath the transducer. So it's typically out of plane because it's so shallow. Or what I also see a lot of people do is build up a sterile gel on the lateral side of the transducer here. So you build up sterile gel, you have your transducer covered, and then people will tilt the probe up and just drive their needle here through the sterile gel and puncturing that ligament down into the joint. If they want to see the needle in its shaft and bevel in its entirety, that way, once you pierce that ligament, you can spin and go bevel down and watch the injectate pour into the joint. But I would say 90% of the time, most people just drop the needle out of plane. But for those that really want to see the needle go in long axis to their target, this is the typical approach. Right here, you can see my finger will start coming in under the right side of the screen, kind of representing the needle's path. So from an AC joint standpoint, that is the extent of the exam, really. There's not much to see in cross-section of this joint, and so it's not typically done. I'm going to go back to my L15 transducer, which has a larger field of view, and we're going to look at the suprascapular notch. So I'm going to follow the scapular spine, which was a great palpation point earlier. I'm going to set the transducer right on the scapular spine. So you can see that superficially right here. Nice scapular spine. And I'm going to aim the beam towards her coracoid. I'm going to keep the probe on the scapular spine, and I'm just going to walk it towards the coracoid. All right, so here you notice I don't have enough depth. All I see is muscle. This is trapezius. This is supraspinatus muscle. I'm going to turn the gain up just a little bit. And I want to prove that supraspinatus by having our patient just do a little chicken wing maneuver, and we'll fire that supraspinatus in abduction, and then back down to the ribs. Good, just hold that. So I need to see the supraspinatus fossa. I'm going to fire the transducer down a little bit deeper, still aiming the probe slightly towards the coracoid process. There we go. And I can see the bottom of that supraspinatus fossa. If you're having a hard time seeing the bottom of your patient's supraspinatus fossa with good clarity, I advise you to drop your frequency for a linear array transducer going through a lot of trapezius and then through the rest of that depth on the neck. Sometimes you have to lower your frequency. So on the Sonosite PX under the MSK exam type, I'm going to select Gen mode, and you're going to see the bottom of the screen brighten up pretty good. There we go. And I think that clarifies that suprascapular notch a little bit better. So here's our notch. And then what I'm going to do is I'm going to aim the probe anteriorly, and then I'm going to sweep it posteriorly. So anteriorly, we see it fall off because I'm just about at the coracoid process itself. And then I'm going to go posteriorly until I see that notch form in the fossa here. That's where we should see a little pulsable artery, and we can check our work with the artery that follows the suprascapular nerve by throwing on our color power Doppler. I'm going to hit the C button on the PX here, and I'm going to drop our color ROI right there. And I have the directional color on by default. I'm going to switch that to color power Doppler with just a button press there. And it should be very dialed in for musculoskeletal blood flow. You shouldn't have to do a lot. But what I like to do to make sure I'm getting the most sensitive setting for my color power Doppler is I bring my gain up until I see noise underneath the bone. So this is all just noise that we're seeing under the bone. Get my arrow to move around. All this little twinkling that you see under the bone is not real flow. I'm going to suspect that this pulsatile steady structure is above the bone. And just to check that, I'm going to reduce the gain underneath the bone until that twinkling color goes away. And there we can see that suprascapular artery right there in the notch really nicely. And we know that that suprascapular nerve is going to border that artery, so that we can use that artery as a guide. You're going to drop your needle down to this level. You know what to hit and what not to hit. If you're doing a deep procedure, this is also a good time to activate the color compare feature on the Sonosite PX. I'm going to select top bottom, so I activate the entire transducer, but here you could drive your needle in real time and see where the color was on the screen, indicating where the artery is versus where your needle might be in grayscale, so that that ROI box and any flash artifact that's showing up is not showing up in your image on the bottom. So the bottom is a live indicator of what's happening on top. And if you're doing a very detailed procedure that requires some sort of arterial landmark, I really do recommend using the color compare tool to drive your needle and also observe where not to put your needle, like in the suprascapular artery here. That's the most common view, but what I'm going to do is just rotate the transducer. Left side of the screen will be anterior. We're going to get a short axis shot. I'm focusing on the bottom of the screen so I don't get all that arterial flash. And I know that the screen left is anterior, so I expect that artery to show up right there on that neck of the coracoid. It's going to start dropping itself right across that slope. There it is, of the supraspinatus fossa. So here's that same suprascapular artery. The angle we were taking earlier is leaning the transducer from the spine of the scapula anteriorly into the wall of the supraspinatus fossa, right as that suprascapular notch forms right here. So we were taking a very hard oblique angle there, and it's kind of nice to see this top bottom where the artery is not in my way. If I were doing a procedure, I would know what to miss and also get a good clear shot of the needle. I'm going to turn off the color compare so we get a full screen. There we go. And a nice look at that artery, as well as the nerve, which is just resting on the bottom of the screen here. There, laying underneath the muscle belly of the supraspinatus. So this whole round structure here is supraspinatus muscle belly. This is a fascial plane that goes between the trapezium, which is transverse here, so this is all trapezium. And or trapezius, I should say. And then here's the trapezium's in the wrist. Trapezius muscle superficially, and then supraspinatus deep there. Diagnostically, if you're doing an exam on the supraspinatus, as we covered in the lateral shoulder and posterior shoulder, I think we briefly touched on it. This muscle should be nice and dark all throughout, all the way up to that fascial plane. You shouldn't see a dirty shadow or rim around the muscle belly. It should be nice and dark right up to the fascia. So that kind of, that really concludes the majority of what we do when we're looking at a superior shoulder exam, plus a little extra. Going into the suprascapular area is kind of bonus. It's one of those things that once you see it, you can't unsee it, kind of anatomy. And you do go kind of check that area out every once in a while, just to see if, hey, maybe there's something invading the area of that suprascapular nerve that you could go check out, like a cyst, maybe a superior labral cyst or something that might be spilling over, because here's that superior labrum right there. You won't see that on everybody, but here's the shadow of the acromion. Here's superior labrum, kind of where the origin of the proximal biceps is. And then here's the superior glenoid tubercle, and then here's that neck of the glenoid, and then here's your suprascapular notch. I thank you for joining us. That concludes the content of the webinar. We'll move on to the Q&A session. If there's any questions, we'll go ahead and answer those now.
All right. As Daniel said, that is it for the recording, so we can move on to the Q&A now. Just a reminder, you can put your questions into the Q&A box at the bottom or the side of your screen. And in order to do that, you'll have to be on the Zoom stream here. So Daniel, it looks like we do have a question already. At what age do you lose the homolog?
So that was a 2020 study I found in the Journal of Orthopedic Research, I think it was. I'll have Chris post it in the chat to anybody who wants a copy of that. But that would be about the age of 40 or 50. There we go. I'm just going to cue that one shot up real quick and drop the question mark here while we get more questions dialed up. Were you able to hear my audio okay, Chris?
Yeah, we can hear you just fine.
Okay, good. I'm just going to ditch the wide shot there. A little technical problem, but we can still see everything really, really nice. Yeah, just as a whole, you know, as we wrap up the rotator cuff protocol, I think it's good just to kind of go over those highlights of the shoulder while we wait on any of these other questions to come in. So we might as well just back that camera up just a touch, and we'll just take a sweep around the rotator cuff fairly quickly, starting at the biceps. And if anybody has any questions, feel free to let them come on in. Remember, we had our palm up in the lap, and we take a look at that biceps tendon and its groove. We've got lateral side, screen left, kind of like you're looking at an MRI. So we're looking at a right shoulder, and I've got the orientation marker facing lateral. So that's a short axis biceps we have on the screen. You take that on down to the pectoralis. If you haven't found any pathology, come back on up into the inner part of the groove. Keep following that short all the way into the rotator cuff interval. Everything still looks pretty normal from here. We come back down into the groove. Keep your hand on the skin. Rotate your transducer with the other hand if you need to, and go long axis on that biceps tendon. So if we go medial, we see lesser tuberosity as a bony peak. If we go lateral, we see the rolling hill of that greater tuberosity. So that looked pretty good. We go back to our short axis biceps groove, and we externally rotate the shoulder. Brings our subscapularis and long axis. We want to go down and evaluate the inferior fibers and aim up because we're scanning a ball. Come on up to the top part of the subscap and aim down. And we're looking for volume loss, tendon retraction, calcium deposits, tendinosis, compressible bursitis. Get the coracoid in the shot by bringing the medial side of the transducer a little bit more superior and get that internal and external rotation of the shoulder.
Looks like we have a little question here. Does she have a tear, or was the dark area artifact?
It's an artifact in this shoulder. The other shoulder is a different story where she has injury from last year. But no, this artifact is called anisotropy. It's an angle artifact. And anytime these fibers take a dive away from the transducer, like that bird's beak portion of the subscap, let's have her externally rotate a little bit further. And we get the enthesis of that to dive almost straight down into the bone. It turns dark. And the way we can combat that is you just chase your transducer out laterally and go parallel with those fibers. And also, you have to confirm any pathology in short axis. So here we are, short axis over that lesser tuberosity. And we can see those musculotendinous slips between the heads of the subscapularis really nicely. And we want to go as far medial as the scan will allow us, which typically you're going to hit the coracoid. So here's coracoid, and one great shortcut is to just go find the coracoid and aim your beam laterally, and you catch a really nice short axis subscap, and then you can chase the fibers from there out to their enthesis. So that's our short axis study of the subscap, and have our patient relax, and then go into our abduction view here. So we've got the acromion process up on the upper corner here, screen right, and then you've got greater tuberosity, screen left here. That shadow of the supraspinatus right there is our anisotropy, so don't call that a tear. And then we have our subacromial space. So before we put our patient into that modified CRAS position that we went over on part 2 on the lateral shoulder, we might as well scan and evaluate what we can see without stressing the tendon. We got good volume through the supraspinatus and long axis. And then I take the proximal corner of that transducer up here by the acromion and just put all your weight of your transducer right there on top of the acromion like we talked about. And then we're going to lay the rest of the transducer right over the cuff structure and have our patient chicken wing out or abduct a little bit slowly. Sometimes passively too is better, but the reason we put our weight right on that acromion is so the deltoid doesn't bump your transducer. It's really, really nice and smooth, and you don't compress any bursitis. So after going through that and evaluating for volume loss, it's pretty safe to go modified CRAS where the hand is in the back pocket. So I've got our hand in the back pocket. Elbow is slightly towards the spine. I like to start in a short axis because that helps me evaluate the volume of the tendon first. So I tend to go short axis. Find your biceps, which is your lighthouse of your rotator cuff. So we've got our biceps here. It's within the interval. Here's the anterior margin of our supraspinatus. We have coracohumeral ligament fibers enveloping the anterior part of the cuff. Posteriorly back here, we've got infraspinatus, supraspinatus here. This anterior 2/3 is supraspinatus. This posterior 2/3 is infraspinatus. And then this middle third, as we go distally and see the superior facet meet the middle facet, that's where you share a conjoined portion of the tendon of the infraspinatus and the supraspinatus. So infraspinatus fibers more or less kind of overlap your supraspinatus fibers, and your supraspinatus fibers tuck under your infraspinatus fibers, and the anterior-most shadow that you're seeing right here is coracohumeral ligament right there where my arrow is. So after you assess for volume loss, you can even wag the elbow a little and look for bursal adhesions. I don't see anything clicking, popping, snapping, dragging, which is really nice. Then I'm going to take this slice here in long axis and just rotate my transducer. Screen left is lateral. I've got our coronal MR equivalent here. And here's our supraspinatus and long axis. Take that proximally as high as you can. And on some patients, you can catch the labrum. I'm going to drop our frequency to gen mode and catch that anterior or superior portion of the labrum right up top. Not a part of the protocol, just bonus if you can see it. And then we look for our proximal or most superior part of that glenoid tubercle for any biceps pathology that we can see there. And then proximal supraspinatus should be passing right through here. There we go. So that's the supraspinatus just before it starts to tuck under the acromion where we lose it. That's why we put our patient in that modified CRASP position. So long axis supraspinatus muscle here. And then I'm going to come on out to the enthesis. Little scanning tip is the anterior part of the greater tuberosity has this inflection point that's curved. And that's just before you hit the interval. So we have a curved greater tuberosity here. And if I go any more anterior, I should hit the biceps tendon in the joint right there. And just a few millimeters laterally, I hit the anterior fibers of the supraspinatus right there. So relatively speaking, my transducers are very much laying right up against that groove where your chest meets the shoulder. All right, and then watch this greater tuberosity flatten out. As that flattens out, we hit the infraspinatus here. So if you see a flat greater tuberosity, you've got yourself infraspinatus. If you see a curved greater tuberosity, you're on the anterior-most portion of it where all the tears occur, and that is supraspinatus right there. Very nice. Okay, let your patient relax. Maybe wiggle their arm around if they have to, if it's sore. We're going to turn and review that lateral and posterior part of the shoulder, the infraspinatus. Here we go. Maybe rotate a little bit more. And back the view out just a touch. There we go. All right, so she's fairly internally rotated, and I know the infraspinatus goes all the way up here where greater tuberosity meets supraspinatus. So here's supraspinatus, and then that posterior third that I talked about was infraspinatus, right? So that's our enthesis right there. I can elongate it, and I'm going to chase that long axis tendon posteriorly, 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 and then a scanning pearl here is that I'm going to lean the top half of my transducer up against the posterior point of the acromion, that posterior edge, and just bump it right up against there, and then you should just be able to lean the transducer into the joint and catch a really, really nice glenohumeral joint. If you see a flat scapula here, and you want to see the spinoglenoid notch, you just want to bring the medial side of the probe north, and you'll see that spinoglenoid notch deepen there. And in the posterior shoulder webinar, we talked about dilating that vein and not calling that a cyst. So we're going to externally rotate the shoulder, and you see this big vein dilate right up in that notch. You just don't want to call that a spinoglenoid notch cyst, because a lot of those paralabral cysts will track down the spinoglenoid notch, causing entrapment on that suprascapular nerve posteriorly. So we're going to have our patient relax. And we can see that infraspinatus really nicely. And then we're going to look at this joint capsule right here as she externally rotates. As she externally rotates, we see the joint capsule fold back over the labrum, and we're looking for any fluid, debris, calcium deposits that might be floating around in there, and any of that is going to sit right there in that little hump. We're going to internally rotate a little bit, and then externally rotate, and get that dynamic evaluation. Short axis is also very important, so we're going to internally rotate one more time. Left side of the screen will go superior until I see the scapular spine. So now we have a short axis infraspinatus, and then further inferior, we see a short axis teres minor. So we're going to add a little bit of gel, starting to run thin. There we go. Okay, so teres minor should be about 1/3 the size of the infraspinatus. We have the infraspinatus and the spine of the scapula here sitting in the infraspinatus fossa. Off the base of that scapula down here, we see the triceps coming in. That's a good landmark if you're taking measurements of the teres minor muscle belly versus the infraspinatus. But this is where we see the inferior margin of that teres minor muscle belly. We could follow that muscle belly out until we hit the humerus, which looks like a hip joint at this point. And that's a great place to go long axis on teres minor. So I'm going to take the slice this way. I'm going to aim from inferior to superior, and we want to pinch this central tendon between the humeral head and the skin so we have a good skeletal reference point. So now I'm just going to rotate the transducer, keep the left side medial, and aim superiorly because of the angle that teres minor is diving. I don't scan like this like a stethoscope, but I want the camera to be able to see that acute angle that we're having to take to go long axis to the teres minor. It's pretty sharp. So you're scanning a ball and we're on the undersurface of the ball aiming up, so we can keep that skeletal reference point. And we could externally rotate slowly and see the teres minor tendon footprint come in, and then internally rotate. Good. All right, so that covers the basics of the rotator cuff structures, and then recapping the AC joint right up top. Supraspinatus fossa contents are bonus, not a part of a protocol, but you might as well check up there and see what you can see when it comes to cysts and other pain generators, like things around the nerve. Is the supraspinatus muscle belly nice and healthy? Is it dark all the way out to the rim? Pretty important to have a nice, healthy, dark, hypoechoic muscle. Meet the hyperechoic fascia. If I go short axis on this, you'll catch that kind of supraspinatus fossa view when we look for a donut sign on things like MRI. You would see a grainy rim around the muscle, and that would be fatty atrophy of the supraspinatus muscle, but we don't see that here. We see nice dark fibers that are consistent all the way throughout that muscle belly. And that's pretty much a review of the shoulder. And in the future, we do plan on having a diagnostic hand and diagnostic foot. And then we'll start our procedural webinars throughout the remainder of 2024. Any questions?
Yeah, it looks like we do have another question here. Would you please show a GH injection location?
Okay, so I don't want to give too much away because we won't have much to talk about in that webinar I just talked about. But in general, the traditional approach, and we covered this a little bit in the posterior shoulder webinar, but in general, the traditional way to do this by ultrasound is to take this view of the glenohumeral joint, all right? And then I want you to bring half of the humeral head to the side of the screen so you're not throwing too much needle and hitting the humeral head. But your entry point at this point, not where you would stand. You don't stand where I'm standing and you don't hold the probe like I'm holding, but I just want you to see about where we are on the shoulder, is that you would enter, there's a factory seam under on the side of the transducer. You're going to go out about 1.5 centimeters away from the probe, and you're going to lay your needle down relatively flat to the probe. And then you're going to align the syringe portion of your injection, align the syringe back with that factory seam, and that's going to keep you in plane. I also suggest that you put the patient in a lateral decubitus position and have them face you with the affected arm up, and their front would face your front, and then you get to hold the transducer like a knee injection. It's very efficient, very comfortable for you. And if you have any vasovagal guys, big tough guys that seem to pass out during injections, they're already laying down, very comfortable for everybody. But you would just take your needle this way. I'm going to freeze the image and just show that trajectory. And ideally what you end up with is a needle landing right under the corner of where the capsule meets the labrum, and your trajectory would be something about like this. And don't forget your steep needle profiling software to really highlight the needle. As you come in any steeper than about 10 or 12 degrees, your needle will start to disappear until you activate that software. I'm going to hit 2D. There we go. Hope that answered the gist of the question, but stay tuned later in the spring or early summer when we have the shoulder injections webinar.
Yeah, as Daniel said, keep an eye out for when we announce those hand webinars. Are there any other things that you want to go over, Daniel?
I think that was a good summarizing exam. You know, we hit the superior shoulder on the topics covered in the lecture. We covered some scanning pearls about where to put your hand and fingers and finger pressure between scanning tips and the actual protocol, and then recapping the whole rotator cuff quickly. I think that was a pretty good summarization of the shoulder. If there are any questions, feel free to reach out to me directly is fine. Daniel.shelton@fujifilm.com, and I'll get back to you on anything else that we can help you with. Or if you're interested in any other topics that we haven't listed, go ahead and feel free to email me those too, and how they would be beneficial to you and your specialty.
Excellent. Well, thank you all for joining us for the shoulder webinar series. Like I said before, we'll be announcing some more webinars soon, so keep an eye on the webinars page on sonosite.com. Thank you so much, Daniel, for taking the time to put together the original presentation and also coming through for the Q&A. Let's see. We appreciate you sharing your expertise with our audience, and thank you so much for joining us today, everybody. We'll see you at the next one.
Thanks, Chris. Thank you, everybody.